Hey everyone, my name is Alexis Bordelon, and this is Case Study 1 for SBCE 638, Section 800. Client Description. The client is a 4-year-old female with an autism spectrum disorder diagnosis at the age of 2. She has been receiving ABA early intervention services in clinic for approximately a year. The client has recently begun to engage in frequent avoidance behavior presented as crying. Crying has been operationally defined as any instance of vocalization, sounds, or yelling, and facial contractions with or no tears, persisting longer than 30 seconds while at ABA table. The behavior has escalated in the recent weeks, becoming a barrier to treatment. What caused the behavior? This particular client was known for having minimal to no behaviors. Her only barrier to treatment previously was attending to tasks. When the crying behavior first began, the function was unclear. The client would put her arms up towards the therapist, ask to be picked up. A few minutes later, she was happy and back to work. This was communicated to the BCBA, in which a hug card was presented for the client to mend when upset. However, as time went on, the crying escalated and continued even when she was held. Additionally, a 3D item discrimination procedure was added to her program, which involved repetitive probe and teaching trials. This was intended to help attending as well as discriminating. Around this time is when she started to exhibit crying behavior during task. The BCBA thought that she may be frustrated by its intensity. The trials were split up and the client was reinforced several times during it. However, the behavior increased and the client refused to respond during this time. The crying behavior had been negatively reinforced by removing her from the table and task at hand. When asked for a hug, the behavior was also positively reinforced by gaining access to being held. What's next? Through direct observation, the BCBA guided therapists to continue the skill presented using least most prompting throughout the behavior. Once the client was compliant and able to complete the task, she was given enthusiastic praise and a highly preferred item or hug if requested. The item was previously determined by using a paired stimulus preference assessment. This worked initially, but as crying escalated, she would engage in the behavior for 30 plus minutes at a time. At this point, it became a barrier to her treatment. After direct observation and completing a functional analysis FA, the BCBA determined that the function of the crying behavior was task avoidance. Due to its intensity and barrier to treatment, a negative punishment procedure was implemented. The procedure was to start a timer after 30 seconds of task avoidance/crying, and after 5 minutes inform the BCBA. The BCBA would then come in, remove her from the table, place a chair facing the wall, and wait until she was calm for 5 seconds. The client would then be brought back to the table, and a master skill was presented. Upon completion of this, as before, she was given enthusiastic praise and a highly preferred item or hug if requested. Intervention. Therapists were taught to use antecedent intervention strategies. This included positively reinforcing behaviors that were you want to see. Notice when the client was becoming upset and when tasks were presented to thicken the reinforcement schedule. This was done by reinforcing immediately after one task was completed. Previously, the client was completing 3 tasks, FR3, before being reinforced. Intervention adjusted to FR1 and increased to FR2 if applicable. Another strategy was to keep reinforcing items on the client's table within sight. This was to ensure she knew preferred items were available upon task completion. Therapists were informed to use motivating operations, MO, when providing reinforcing items. For example, she would often not eat breakfast before coming to clinic. Therefore, during morning session, working for a snack will be more reinforcing than a toy. Throughout the course of intervention, the reinforcement schedule varied. As previously mentioned, before intervention, reinforcement was an FR3 schedule. Once the intervention was implemented, For task avoidance behavior, the schedule became FR1. After approximately a week of intervention, the schedule was FR2 with the exception of receptive ID or matching task involving cards. Since a barrier from the beginning was attending, when the client did attend, therapists were instructed to immediately reinforce FR1. This was to ensure we were reinforcing desirable behaviors and the likelihood that they would increase. Maintenance. In the clinic setting, the client also received occupational and speech therapy. These professionals were informed of her avoidance behavior and encouraged to use a similar reinforcement schedule. Due to the consistent reinforcement schedule, the client was able to attend longer without problematic behavior across settings and professionals. As time went on, task avoidance decreased and intervention was adjusted. The BCBA faded out the previously placed punishment procedure. When avoidance behavior arose after a 30-second timer was started and the therapist continued to run programs. During the behavior, she is positively reinforced with the preferred item after every 2 skills, with the exception of receptive ID or matching tasks including cards. Once calm for 5 seconds, the timer is turned off and AB continues as normal. The client's reinforcement schedule thinned to FR4, while still keeping the exception of receptive ID or matching task FR1. Task avoidance presented as crying behavior is no longer a barrier to the client's treatment. The behavior occurs occasionally but remains mild no longer than 5 minutes. Intervention was successful. References used for case study 1 was the Cooper textbook.